So INI-CET 2023 ENT recall by Dr. Prateek Garg. So let's start with the first question. The picture was being given in the examination, and the examiner want to ask, name the now block in this procedure. So as we can see, examiner is inserting the syringe and giving the anesthesia drug at the level of medial canthus of the eye, between the dorsum and the medial canthus, in between there. So examiner is giving some injection, and examiner want to know, name the now block in this procedure. And hopefully these four options were there. First was nasociliary nerve, second was sphenopalatine nerve, third was anterior ethmoidal nerve, and fourth was probably Vidian's nerve. So basically in the nose, the dorsum of the nose, suppose this is my dorsum of the nose and this is my eyes. So generally when we put the injection over the dorsum of the nose, lateral border, and we go 1.2 centimeter deep, 1.2 centimeter deep if we go. So generally what comes here is mainly the nasociliary nerve, which is coming from behind, giving the branches like posterior ethmoidal, anterior ethmoidal, then multiple branches to the ciliary ganglion. So let's understand this better by this diagram. So this is a diagram of the nose where we can see this is my trigeminal nerve. That is a fifth cranial nerve, trigeminal nerve. And from the trigeminal nerve, there are three branches are arising: V1, V2, and V3. V3 is maxillary, V3 is mandibular, V2 is maxillary, and V1 is ophthalmic division. And from this ophthalmic division, one branch coming out, that is nasociliary nerve. As you can see here, nasociliary nerve. This now further goes, giving multiple branches to the ciliary ganglion, the ganglion shown here. And then further it gives the first branch, that is posterior ethmoidal, which is a branch of nasociliary, then continue ahead in the anterior part, and then gives a branch which is anterior ethmoidal nerve. So basically whenever we are doing the surgery of the nose, suppose there is a nasal bone fracture, suppose there is some other part, we have to do the rhinoplasty or something like that. So what we can do, we can inject the anesthetic drug around 1.2 centimeter deep from the surface, from the outer surface, 1.2 centimeter deep, and we will directly put the anesthesia drug to anesthetize mainly the nasociliary nerve. More correctly, if they want to ask, we can say anterior ethmoidal nerve, but basically it is anesthetizing the nasociliary nerve. So this question where examiner is giving that some injection is being given over the lateral surface of the dorsum of the nose. So basically the correct answer, name the nerve block in this procedure, the correct answer should be nasociliary nerve. If suppose nasociliary nerve is not an option and other options are given, sphenopalatine, anterior ethmoidal, Vidian, and posterior ethmoidal, then we can go for the correct answer is anterior ethmoidal if nasociliary nerve is not given. But since to anesthetize this portion, what we do, we are injecting the anesthetic drug to anesthetize the nasociliary nerve, which is further giving branches like posterior ethmoidal and anterior ethmoidal nerve. So more correct answer, which I feel, is nasociliary nerve. If it is not an option, then definitely we can opt for anterior ethmoidal nerve. So basically, if we draw the diagram of the nose, so we inject the syringe going deep, around 1.2 centimeter deep, then we'll put the anesthetic drug and it will anesthetize the nasociliary nerve and its branches. So not so difficult question, it is quite simple question. Let's talk a little bit about the other branches also, like V2, how it is going. V2 is maxillary nerve, V3 is mandibular nerve. V2, we all know maxillary nerve is entering into the sphenopalatine fossa. Sphenopalatine fossa, as you can see, this is suppose the posterior part of the maxilla. This is the pterygoid plate. So Sphenopalatine fossa or pterygomaxillary fossa. We can both the same. So here you can see the maxillary nerve is entering here, forming a ganglion. Ganglion is known as sphenopalatine ganglion because it is between the pterygoid plate of the sphenoid and the palatine bone. Okay, and from there, this fossa, this maxillary nerve then coming out in the infraorbital, there is a fissure running in the upper surface, superior surface of the maxillary sinus, and then coming out from this foramen and then spreading its branches over the cheek, over the lateral surface of the dorsum of the nose. Next question. Match the following with the regards to thyroid swelling obstruction. So next question is match the following with the regards to thyroid swelling obstruction. That means the patient is having big thyroid swelling, and what can be the symptoms if that swelling is compressing a particular structure. So we have to match. Suppose the swelling is compressing the trachea. If swelling is compressing the trachea, then what could be the symptom? Trachea is an air pipe. So what can be that? There can be dyspnea. If esophagus is being compressed by the thyroid, so what can be the symptom? There can be dysphagia. Because if esophagus, the food pipe, is compressed, that will be result in dysphagia. If recurrent laryngeal nerve is compressed, then what can be the symptom? Recurrent laryngeal nerve, damage, injury, paralysis, whatever thing is happening there, that will lead to hoarseness of voice. Hoarseness of voice. The voice will be changed. If there is aberrant palsy, one of the vocal cord will not be able to move. That will fix in cadaveric position or paramedian position or median position, depending. But then what will the symptoms? Symptoms will be hoarseness of voice. There will be change in voice. And lastly, sympathetic chain. We have heard so much of time. We have read this. Sympathetic chain injury, sympathetic chain damage can lead to Horner syndrome. Very simple question. Nothing to worry about it. It's very easy. If trachea is compressed, there will be dyspnea. If esophagus is compressed, there will be dysphagia. RLN damage, there will be hoarseness of voice. Sympathetic chain damage may lead to Horner syndrome. Horner syndrome includes of myosis, ptosis, anhidrosis, like that. So, what is the correct sequence? Correct sequence is A4, B1, C2 and D3. So look at the option, which is the correct answer. A4, B1, C2, D3. So this is the correct answer. Option number C is the correct answer. Not a big deal in this question. Very simple question. All examiner want to ask if there is a big thyroid mass that is putting pressure over different structure. So depending on which structure is compressed, what can be the symptom? So we have to match that. Very simple in that. So let's move on to next question. Arrange in order of BARA. So suppose BARA, what do you mean by BARA? Brain stem evoked response audiometry. This is very, very important. BARA is always asked. Brain stem evoked response audiometry. Okay, so basically BARA, whenever we put the electrodes over the different parts of the brain stem, and we put we give the auditory stimulus or electric stimulus or whatever it is. Then we record that electric activity happening in the brain stem. So examiner want to ask, what is the correct sequence in order of BARA? That means BARA, we all know BARA consists of 7 waves. There are 7 waves in the BARA, out of which 5th wave is, we can see the most important wave. So how this is happening, BARA waves? So let's talk about this. Suppose this is my ear, external ear. Then there comes the middle ear. Then there comes the inner ear. From the inner ear, there occurs spiral ganglions. Spiral ganglion will form the cochlear nerve. So this is the distal part, this is the proximal part towards the brainstem. This is the cochlear nerve. Then this cochlear nerve, this will further go to cochlear nucleus. Then this cochlear nucleus, we remember by a mnemonic SLIM. S stands for superior olivary complex. L stand for lateral lemniscus. I stand for inferior colliculus. And M stand for medial geniculate body. And from there, these fibers further go into superior temporal gyrus, or we can say auditory cortex. So basically in BARA, what is happening is wave 1 to 7. How are these numbered? Wave 1 is distal part of cochlear nerve, so the spiral ganglion. Then comes proximal part of cochlear nerve, that is proximal to the brainstem. So that consists of wave 2. Second wave. Then third wave is at the level of cochlear nucleus. Then fourth wave is at the level of superior olivary complex, and fifth wave is at the level of lateral lemniscus. And then sixth wave is like this. 6, 7, they're basically from the inferior colliculus, not the medial geniculate body. So they come from the inferior colliculus. Nothing to remember. We have to remember mainly up to level of the 5. From the wave 5 is coming from the lateral lemniscus. Now, examiner want to ask what is the correct sequence in which the BARA waves are recorded. So we understood that the first wave is from the spiral ganglion which is present in the cochlea. So A is the first. A would be the first. Then comes cochlear nucleus, then comes distal part of the cochlear nerve, which is not in the option. Then next comes cochlear nucleus. Then next come after cochlear nucleus, superior olivary complex. After superior olivary complex, what is there? Lateral lemniscus. After lateral lemniscus, what is there? Inferior colliculus. After that, there is medial geniculate body. And after there is auditory cortex. So I hope A, B, C, D, it is already given in the correct sequence. Already given in the correct sequence. So what examiner want to ask? Select the correct answer from the given below code. What is the correct sequence of the BARA recordings? That is the BARA waves. Wave 1, 2, 3, 4, 5, 6, 7. So like that. So it is the correct sequence. So correct answer should be A, B, C, D, E, F, G. A, B, C, D, E, F, G, which seems to be correct. So correct answer is A. So nothing to worry. Very simple question. We all know how the auditory pathway occurs. So BARA is having the same pathway, auditory pathway. So examiner indirectly asking for the auditory pathway. So BARA is nothing but brainstem evoked response audiometry, where we consist of 7 waves. Through the BARA, we can detect the lesion of cochlear lesion, retrocochlear lesion, or whatever the site of the lesion. We can get the idea that at this particular site, the lesion is there. We can detect the lesion of the cochlear nerve, we can detect the lesion of the cochlear nucleus, we can detect the lesion of the superior olivary complex or lateral lemniscus, or whatever the reason is. So BARA is very, very useful investigation. And the best part of BARA is it can be done in utero. Baby is not even born. So it can be done in utero. It can be done in utero. You can get the result at 34 weeks of gestation. Baby can hear the inner ear is built up at that 20 week of gestation. 20 week of gestation, baby inner ear is completed. Okay, so BARA, if examiner want to ask when can be BARA done, so it can be done in utero at 34 weeks of the gestational period, and it is one of the best investigation to rule out the pathology along the auditory pathway. And what is the correct sequence? Wave 1 from the distal part of cochlear nerve, wave 2 from the proximal part of the cochlear nerve, the wave 3 from the cochlear nucleus, wave 4 from the superior olivary complex, and wave 5 from the lateral lemniscus. So this already A, B, C, D, they are in correct sequence. So correct answer should be A, B, C, D, E, F, G. So let's, this is a simplified diagram just to show you how this auditory pathway is happening. So this is our cochlea, these are cochlear turns. As we can see, these are our cochlear turns. From the cochlear turns, the auditory, this cochlear nerve is going on, that is the 7th cranial nerve. From the 7th cranial nerve, then these are going into the cochlear nucleus, which is the cochlear nucleus indicated here. And from the cochlear nucleus, then it goes to superior olivary complex, then goes to lateral lemniscus, which is a part of pons. Lateral lemniscus is present in the pons. Superior olivary complex itself present in the pons. and this nucleus are present in the cochlear nucleus is present in the medulla. So from the medulla it goes to the pons. Pons lies the superior olivary complex and lateral lemniscus, and from the lateral lemniscus part of the midbrain which consists of inferior colliculus and the medial geniculate body, and from their medial geniculate body then fibers are going directly to the auditory cortex. Auditory cortex is superior temporal gyrus. There are two areas in the auditory cortex. One is the Broca's area and other one is the Wernicke's area. Wernicke's area is the sensory center which receives the sound, processes the sound, analyzes the sound. So it is area number 42. And Broca's area is the motor area. Suppose if we understood whatever the sound is coming, what is the meaning of that sound, so that understanding of the speech of the sound is by means of Wernicke's area, and then brain understand, then process, then we give the command to say this. We have to answer something we understood, then we will give the command. That command is coming from the Broca's area. So if suppose there is a deformity pathology in the Wernicke's area, that is a sensory area, receptor area, then patient will be unable to understand the speech. Whatever he is listening, he can listen, but he can't understand what is the meaning of that. If suppose there is a lesion of Broca's area, that means patient can understand what is going on, what the speech is coming on, but the command, the voice command, the answer he has to say is not proper. So he can't make the proper sentences because of defect in the Broca's area, and these are present in the superior temporal gyrus. Next question. An elderly male come up with a polyp hanging from the nose. As you can see, in the nose there is polyp, there is pinkish reddish polyp. He takes a bath in pond regularly. What is the diagnosis? So look at the picture. We have seen this picture multiple times whenever we are studying the theory part. You can go in the notes itself. So there is a typical pinkish red polyp. There is no history of bleeding as not mentioned here. Firstly, only history is given is patient is taking a bath in the pond. Some of the students were saying that it was written that South Indian male come with the polyp hanging from the nose, which was a bleeding polyp. Occasionally, he used to take a bath in the pond regularly. What is the diagnosis? Now look at the option: rhinoscleroma, rhinosporidiosis, pemphigus vulgaris, and nasal polyp. So this picture, this particular picture, we have seen so many of the times in the theory part. By looking at the picture only, I can say that this is a typical picture of rhinosporidiosis. Why rhinosporidiosis? Because rhinosporidiosis is being caused by an aquatic protozoa. Aquatic, that means that protozoa is particularly present in the ponds. So person who they regularly take a bath into the small ponds which are not very neat and clean. So this aquatic protozoa, the name is Rhinosporidium seaborrhei. Okay, so this is present in the generally ponds, and from there it will go irritate the mucosa, form a polyp which may be bleeding. There can be whitish dot over this polyp. As you can see here, some white dots. You can appreciate the white dot. So this is typically the sporangia. The growth are coming. So this whitish dots like a strawberry. You have seen the strawberry. So big mass with the whitish dots representing the sporangia. This is a typical picture of rhinosporidiosis. So generally this rhinosporidiosis is present in the South Indians. Because of the humid climate, they are usually taking bath in the ponds, and everything in this humid climate favors this particular infection. So rhinosporidiosis, it will having the strawberry-like mass. Strawberry-like mass. And what is the treatment? It is a bleeding polyp also. What is the treatment? Treatment is excision. Completely excise this polyp with cauterization of the base. And any drug which can be used here is the dapsone. Dapsone can be used, but the mainstay of treatment is excision of the polyp with cauterization of the base. Okay, and this is appearances like strawberry like mass with a whitish dot over the structure. So this is a typical picture of rhinosporidiasis, which is the correct answer. Why not other options? Suppose nasal polyp. Why not nasal polyp? Nasal polyp are not red, they are pale. They have nothing to do with taking a bath in the pond. No relation. It is basically allergic. Hereditary prefactors may contribute, but nasal polyp generally they are pale, they are not reddish. Okay, and there will be multiple polyp over both the sides. Rhinoscleroma, we have studied this. Rhinoscleroma is typically present in North India. And there are 3 stages in the rhinoscleroma, which is being caused by a bacteria which is known as rhinoscleromatis. So basically rhinoscleroma, rhinoscleroma, it is having 3 stages. First stage is atrophic, like atrophic rhinitis stage, where the mucosa, the nerve, the blood vessels, they get damaged. Then the next stage comes granulomatous stage, where a big granuloma will form. And the last stage is stenosis, cicatricial stage, where there will be stenosis of the nose. So basically it is caused by the gram-negative bacteria. Pneumophilis rhinoscleromatosis. What is the treatment? Treatment of rhinoscleroma is basically streptomycin, tetracycline, these drugs of the rhinoscleroma that should be treated in the early stage, because early stage the atrophic rhinitis like symptoms are there, where the nasal cavity will be very roomy, there will be damage to the septum, there can be damage to the mucosa, blood vessel, there will be atrophy of the inferior turbinate leading to white roomy cavity. Then say this stage will further proceed to granulomatous stage, where the multiple granulomatous tissue will form around the nose, which will give nose a different structure, different shape, like tappy nose, woody, hard nose, big nose, granulomatous, multiple granuloma, and then further that will heal by stenosis of the anterior nails, stenosis of the nose, resulting in stenosis of the nose. So that is rhinoscleroma. So the correct answer by looking at this picture is rhinosporidiasis, and the clue factor which examiner is giving only is like the taking a bath in the pond with the strawberry like mass with the whitish dot over it, which is suggestive of strawberry like mass, which is suggestive of rhinosporidiasis. Next question. A 14-year-old female presented to ENT OPD complains that she can understand the language and hears the sound, but unable to understand the meaning. So what the baby female 14-year-old female patient is complaining, she can hear the sound, understand the language, but unable to understand the meaning. That means sound is being perceived, but the concept, the meaning of that sound is not being obtained. Her PTA, pure tone audiometry, and ABR, brainstem reflex, that is a BARA, is normal. So her PTA and ABR is normal. Brainstem reflexes are normal. Pure tone audiometry is normal. Middle latency response is abnormal. Now the key factor is middle latency response. What is a likely diagnosis in the patient? We have already talked about the auditory pathway. Recently, we have already talked about the auditory pathway. What is the auditory pathway? So if suppose a patient can perceive the sound, that means the nerve, the nucleus, then the rest of the pathway, slim. These all are working normally. So whenever the sound is reaching to brainstem, to the brain, auditory cortex. So to understand the speech is a function of brain. That which part? Vernix area, which we have already discussed. Vernix area in the brain, which is nothing but area number 42. So the female is having complaint that she can perceive the sound but can't understand the meaning. And pure tone audiometry is normal. Pure tone audiometry is normal. That means the middle ear, external ear, inner ear are working absolutely normal. ABR is normal. ABR is normal. That means brainstem is also normal. That means this brainstem is normal. If bara is showing normal, that means the brainstem is also normal. So clearly the pathology lies in the brain, which is to understand the sound. Middle latency response is abnormal. Middle latency response is particularly a response from the brain, from the superior temporal gyrus. So let's look at this question. So this is our brain. In brain there are two areas. Oh, one next area I've written 42. It is 22. Okay. Yeah. So in brain, basically to perceive the sound, the auditory cortex is temporal gyrus. Transverse temporal gyrus or superior temporal gyrus, whatever you want to say. So basically temporal gyrus. And in this, two areas are there. One area is Wernicke's area, other area is Broca's area. Broca's area is area number 44, which is a motor area. It gives the commands, form the speech. Whatever patient understands, then in response to that, whatever he commands, whatever the speech is giving, that is by the Broca's area. Wernicke's area is a sensory area. It perceive and understand the speech. Whatever we are listening to understand the speech is a function of Wernicke's area. And in this patient particularly, patient can't understand. And the bara and the putative audiometry is normal. That means the auditory pathway is normal. That means the middle ear, external ear, inner ear is normal. So clearly the pathology lies in the brain, and particularly if I see the pathology lies in the Wernicke's area. Wernicke's area, that is area number 22. What is our likely diagnosis in this patient? Malingering? No. 14-year-old baby can't understand the speech. That is not a symptom of malingering. So correctly, it is not the correct option. Autosclerosis? No. Because in autosclerosis, pure tone audiometry will be abnormal, and there can be bara will also generally autosclerosis, because it's a middle ear pathology, there will be pure tone audiometry will be abnormal. Mischel aplasia. Mischel aplasia. Aplasia means absence of cochlea. That means this is cochlear abnormality. Aplasia means absence of cochlea or deformity of the cochlea. So suppose if cochlea is abnormal, then bara or ABR reflex will be abnormal too. But clearly examiner has mentioned that ABR is normal. That means cochlea is working normally, the brainstem is working normally. So it can't be Mischel's aplasia. It can't be this. It can't be autosclerosis because pure tone audiometry is normal. It can't be malingering. So only option left is Wernicke's aphasia or auditory neuropathy, whatever the option given was there. So clearly if somebody can't understand the meaning, that means the pathology is somewhere in the brain. And in brain, which area? Wernicke's aphasia or maybe auditory neuropathy. So by looking at the option, we can easily say the correct answer is Wernicke's aphasia. So clearly these are 4 to 5 questions which we got in 2023 INI-CET exam. I don't think the questions were very difficult. They are very simple questions. Completely from the theory part, whatever we have studied, we have to apply just the knowledge and the concept, and we can correctly answer all of them. So that's all about INI-CET. Thank you.